Thank you so much for your previous talks. They're brilliant. Very good to listen to colleagues and the progression of emergency medicine, isn't it? My talk is about Iceland, but I am Swedish, so I feel that I should probably present myself as that. My name is Rasmus Strandmark. I'm an emergency physician trained in Sweden in Eskilstuna, finished my residency there with rotations to Cape Town and Reykjavik. Nowadays I work in the Landspítali University Hospital in Reykjavik, and I'm also a PhD student at the Háskóli Íslands. I have a lot of interests and conflicts in this subject, but none of them have so far resulted in any significant cash flow into my bank account. Feel free to send me money afterwards. As I said, I'm Swedish, but nowadays I'm trying to do my best to become an Icelander. I moved 2.5 years ago, a great country you should come visit. So I've had the privilege to work in both the Swedish and the Icelandic setting, and that of course have led me to reflect a bit on the differences between the two countries. And what has fascinated me most is that two culturally so similar nations have adopted such different strategies when it comes to implementing emergency medicine. If anyone heard my talk on this at SWESEM in Copenhagen, I compared the evolution of the specialty in these two settings. Today I'll try to focus more on Iceland, but I need to start at the beginning. Emergency medicine is a passion to me. I love what I do. If it's removing 2 magnets from a boy's lingual frenulum or doing an awake intubation for a crashing asthmatic. But this wasn't clear to me initially. During my last year of internship, I was steadily feeling an increased anxiety level, nearing the state of panic, because I couldn't see myself going into any of the existing specialties. And frankly, emergency medicine was at the bottom of my list. At the time, it had just become a separate specialty on paper. But what emergency physicians were doing was very far from what I felt that emergency medicine is. Basically, it was sorting out low priority patients that no one else wanted to take care of. But I had to go somewhere. So in desperation, I let myself be persuaded to go to talk to the emergency director at the time. And as it happens, she was brilliant in her sales talk. And that's her on the right, by the way, Birgitta, lovely person. And if you look at me, you could almost see that I wasn't convinced, right? Not at all happy and comfortable being in this ad. Anyway, Birgitta said to me, okay, listen, mate, no one here knows what emergency medicine is, including me. But the hospital says it wants it, and they've given me this pile of money, so here's the deal. I'll employ you for 5 years, and you'll find out what it is that you need to learn, and a way to learn that, and then you'll just go do whatever that is. And I said to her, you know, I don't have anything better to do, and I do like a talent, so why not? And I'm very grateful and happy for that today. But despite the hospital investing generously into my education and my colleagues' education, with time it became clear to me that implementing emergency medicine, as it's understood internationally and defined internationally, wasn't part of the plan. The hospitals weren't really implementing emergency medicine as such. They were rather sort of trying to solve high staff turnover by employing junior doctors to work more steadily in the emergency departments. So there were no notion about the system having to change in any way. And there were no clear plan of what the future specialists would do in the daily work. And experiencing this and realizing it, that made me the uncompromising dogmatic that I am today. In Iceland, things started with this man, Jon Baldursson. He had gone over to the States soon after the specialty was recognized over there. And after completing his training in the Department of Emergency Medicine at the University of Cincinnati, he moved back to Iceland in 1991. He applied to become Iceland's first emergency physician. Now, as emergency medicine didn't exist in Iceland yet, it took almost a year for the Directorate of Health to approve his application in 1992, and the specialty was formally approved 2 years later. Jon got employed in the orthopedics department to manage their ED. At the time, the Icelandic population was quite young compared to the European standard, so most of the ED flow was minor trauma. And as you might be aware, orthopedic surgeons aren't necessarily primarily interested in seeing the undifferentiated patient in the emergency department, right? So they're quite happy to let someone else do that. So when Jon made it clear to them that emergency physicians do not provide definitive care, they handle emergencies and hand over the patient to other specialties for further management, this was accepted. And I think that might be perhaps the most pivotal moment that made emergency medicine evolve differently in Iceland compared to Sweden. Another important factor is education. It's been a long-standing tradition in Iceland that you'll do your residency abroad. There's no residency programs in Iceland traditionally, and emergency medicine adhered to this tradition, not starting their own residency program for the longest time. Instead, they constructed a 2-year foundation program for doctors that wanted to prepare for residency abroad. And between 2008 and 2010, they partnered with the Faculty of Emergency Medicine at Harvard Medical School to get experienced emergency physicians to Iceland to help with training and developing the specialty. It was not until the department was fully staffed with competent consultants trained abroad that the decision to implement a residency program was made. Instead of constructing a program from scratch, Iceland reviewed available training programs from existing systems and came to the conclusion that the Royal Colleges program would be best suited. So they partnered with the Royal College and implemented the 3-year core training program in 2016. It was still mandatory to go abroad to complete your training at that time. And in 2019, Iceland was approved to provide the full 6-year program, still keeping a mandatory rotation abroad of a minimum of 6 months, mostly done in New Zealand nowadays. So much of the way things were done was shaped from the tradition of an existing system and then adapted into the Icelandic. Iceland's model never intended for emergency physicians to replace on-call services or overlap with hospital wards. Instead, emergency medicine was designed from the start as its own specialty, using the template of working systems from other countries. This strategy adheres to 2 rules. Rule number 1, it has to be established that the emergency physician is solely responsible for the patient as long as the patient is in the ED. No other specialty can interfere or take over patient care. Rule number 2, once the patient leaves the ED, the emergency physician's responsibility ends. All further care has to be decided on and executed by the receiving service. I personally would go as far to say as it's not really emergency medicine unless these 2 conditions are met. But if they are, almost everything else can vary. You could admit early, leaving most of the work up to the recipient. You could work up the patient all the way to diagnosis before handing over, all depending on the capacity of your ED and the receiving service. You can be liberal in asking for help by other services, or you could be expected to do everything on your own in the ED. It doesn't matter. It's still emergency medicine. But if these two rules are not met, it's something else. It might try to present itself like emergency medicine, but it's not. This might be controversial to some. But if you think on it, it shouldn't really be, because it's true for all other specialties. Right? The boundaries between the different departments are non-disputable. You wouldn't see internal medicine waltzing into the orthopedics ward and starting to care for patients. Even though that would probably save lives, they wouldn't do that. Because it would be disrespectful, and the patient, the responsibility would be unclear. And they would also not ask one another to write admission notes or plan in-hospital care for them, because again, that would be disrespectful, and the patient responsibility would again become unclear. In Iceland, the second condition, that emergency physicians do not deliver definitive care, has been the norm from the start. And the first condition, that emergency physicians solely carry the responsibility for their patients in the ED, has been explicitly confirmed in writing by the hospital director. In Iceland today, emergency physicians take full responsibility for patients in the ED, practicing the entire spectrum of emergency medicine. This has not solved all challenges with a healthcare system. Things like boarding, profound. Staffing shortages exist. Unacceptably long waiting times, absolutely. The service we provide is not flawless, far from it. However, I believe that having emergency physicians engage on equal terms with other departments, having the autonomy to make crucial decisions, and shouldering the full responsibility, even when it's difficult, is beneficial to our patients. A lot of people keep telling me that this can't be done in Sweden. Of course it can. The North Americans, they've relied on this system for 50 years now. Yeah, but that's different. It's really not. But okay, how about the British, the Australians, the New Zealanders? No, they're all British. Okay, how about the Belgians? The Belgians, I have no idea what the Belgians are. I'm sure they're nothing like us. Okay, so how about another Nordic country, as similar to Sweden as any country could ever be? It's practically the 22nd region of Sweden. Don't tell me it can't be done. Well, it's not safe. What do you mean? Yep. You will never be as good as the experts. You should leave it to the experts. Actually, the opposite is true. Implementing emergency medicine with core competent emergency physicians that can tackle any and every emergency that comes up is a safety measure. Emergency physicians are there saving the eyesight of people with orbital compartment syndrome, doing the lateral contotomy considerably faster than the ophthalmologists. Emergency physicians are there detorquing manually any testicle torsion that comes through the door, significantly improving patient outcome. Emergency physicians are there doing advanced airway management whenever and wherever the patient needs it. Don't let anyone convince you that you cannot achieve the competency that this demands. You can. It's been proven. Don't let anyone convince you that you can't form an autonomous emergency department capable of doing all these stuff, being trusted from the society and being respected by the other departments in the hospital. You absolutely can. Thank you.